Hi Ninja Nerds, in this video we're going to be talking about gestational diabetes. If you like this video, give it a thumbs up, comment down below. Don't forget to subscribe and also check out ninjanerd.org where we have all our notes and illustrations for all of these lectures here on YouTube, but let's get into it. When we talk about gestational diabetes, we're also talking about GDM. And what this is not pre-existing diabetes and then someone gets pregnant. This is not diabetes in general in any other sense than a woman who gets pregnant and has problems with insulin regulation. So we're going to be talking about impaired glucose regulation in a pregnancy change, as well as the first recognition of it during pregnancy. So how do we figure out that this person has gestational diabetes? What's going on? What's the screening process? And typically we do get screened around 24 to 28 weeks, but the whole goal of this lecture is to understand what gestational diabetes is and how does this influence not only mom, but also baby. Let's quickly recap and talk about what insulin is. So we have to remember that insulin is a hormone. I think a lot of people forget that it's a hormone. It's a hormone that is produced by our beta cells in the pancreas, and what it is used for is to help regulate that glucose. So I always picture hormones as switches. They're just signals that go around, and they're helping turn on and turn off different type of pathways within our body. So if we have a problem with insulin and we have a problem regulating insulin, then we have a problem turning on different switches and doing other things within our body. So let's just dive into the pathophysiology a little more, get in a little more in depth on what all of those components are. So with the pathophysiology, let's break it down to the basic essentials here. You eat something, right? And when you eat, you're taking in some carbohydrates, you're taking in sugars, you're taking in all these different types of things, and your sugar goes up in your blood, right? Your glucose increases. And then from there, it triggers your body to say, my pancreas needs to now start to release insulin or increase insulin in the blood. Right? And that's our simple pathway there. We eat, we have a increase in our blood sugar, and there we have to increase our insulin in order to bring that blood sugar back down. And we're going to get into that a little more in depth here with the pancreas. We talked about the pancreas and its beta cells in the islet of Langerhans, and what happens is our pancreas gets that increased signal of increased blood sugar, and it says, I'm going to release some insulin. When I release insulin, it's going to go to different target organs. And what it's going to do is it's going to tell those organs, hey, let's take sugar. There's sugar available. Let's take it up. Let's do some things that we can help use this sugar. So it goes to the liver, and it goes to the adipose tissue, and it goes to the muscle. And they all uptake this sugar, right? They all take sugar up. And there's different pathways that they use, right? They all take sugar. There's glycogenesis, there's lipogenesis, we use GLUT4 uptakes, and what we do is we increase the uptake of glucose. Because we do that, there's less glucose now available within the blood, and therefore our sugar drops, right? Hope that makes sense. So what we have to look at now in pregnancy is where is that flaw? Where is that issue with sugar within the blood? And therefore we can't regulate it as correctly. What's going on? What's the problem? What's the disruption in this pattern? So in this, we're going to look at two different things. We're going to look at the fetal demand, right? Because now we're not dealing with somebody who's just having trouble with sugar regulation. They're also pregnant, so we're also trying to grow a baby. And we also have an added component of the placenta, right? When a mom is pregnant with baby has the placenta. We have the cord going to baby, taking blood back out to placenta and back out through the mom. So it's all continuous one circulation. So first, let's just go with the shorter route, which is I think one that's a little more easier to understand, is fetal demands. So we have mom, and again, mom is not getting screened for this around 24 to 28 weeks. She's not getting it done right away, and that has to do with also the fetal growth, right? Baby is growing within this process, within these weeks. So as fetal demand increases, because baby is growing, and baby isn't able to eat, it's not able to take in its own sugar, so baby's going to get sugar from mom. So mom's going to eat. Mom's got sugar. As baby grows, as baby grows, baby's going to want more sugar. So they're going to increase that fetal demand. So that's going to say, hey, I'm going to have to eat more sugar, so mom's going to eat more. Because of that increase of the glucose, we're going to have the increase of the insulin production. We have more glucose coming in, we're going to make more insulin. Because of that, our pancreas is going to increase its beta cells. It's going to increase these numbers, right? It's called hyperplasia. And this hyperplasia is going to tell the pancreas, let's make more insulin, let's make more cells to make more insulin, let's keep going, let's keep going, let's keep trucking along. We got to make more insulin, got to make more insulin. And over time, those cells can't keep up, and eventually they're going to fail. We're going to have a decrease in insulin because now our pancreas is petered out, it's tuckered out. It's like, I can't do any more of this. So the insulin's going to drop, and now over time, we're going to have that increase in glucose. So we're going to have that prolonged hyperglycemia. That is one pathway. And on the other side here, we have the same similar pathway that we can also get to gestational diabetes, right? What we're looking at here is our placenta. Our placenta produces all these other hormones, right? Within the body, it's got the human placental lactogen, it's got the cortisol, the progesterone, the estrogen. It's all increasing these numbers. And over time, pregnancy, that can also increase insulin resistance, right? Which means to us is that we are not going to be triggered, right? All these pathways over here are not going to be triggered by that insulin. So because of that, it's going to decrease that insulin uptake. So now our liver, our muscles, our adipose tissue is not taking out that glucose from the blood. So because of that, we have a trigger of an increase in glucose. That increase in glucose is also going to say, hey, pancreas, let's go, let's make more insulin, let's produce more insulin. And it's going to run down that same terminal of making more cells, increasing the insulin, and over time it's going to fail. That's going to have a decrease in the insulin in the cell, and then we're going to have the hyperglycemia, that increase in glucose over time. And that, in a nutshell, is the pathophysiology of what's going on with gestational diabetes. But how do we get to this point? What is going on that we go from mom having pregnancy that's normal to all of a sudden mom having diabetes during her pregnancy? So let's talk about some of the risk factors and complications that go along with this. All right, Ninja Nerds, so let's talk about the risk factors that go into gestational diabetes. So what we're looking at here is some things that can cause an increase in either insulin resistance, where they have trouble regulating insulin, or even indicators that possibly down the line a patient might develop diabetes. And what you're looking at here is a mom is having exacerbations that throughout the body might occur later in life, because people that tend to develop type 2 diabetes develop it later in life. But there is some risk factors that the mom can have now that can potentially exacerbate that along with being pregnant. One of them is just the maternal age. They have found that there is some research that if you're over 25, you have more of a chance to develop diabetes, gestational diabetes, and then if you're over 35, you have even more. If you have that advanced maternal age, it's even more of an increase. There is also a correlation with an increase of the BMI if you have multiple gestations, so if you got more than one baby in there. And we also have PCOS. If you have polycystic ovarian syndrome, you have some type of issue with regulation, insulin regulation, you can also have that down the line, having trouble with gestational diabetes. But let's go into the signs and symptoms, because that's where I think you're going to understand the most as well with gestational diabetes, is what's going on. So we have that decrease in that insulin now. So we're continuing from what's going on over on the pathophysiology. So we have that decrease in insulin because our pancreas is now tired. It's not able to pump out that insulin anymore. And we're going to have that increase in the blood glucose, which we call hyperglycemia. So now mom is experiencing hyperglycemia, and baby as well is experiencing hyperglycemia because baby doesn't have its own regulation of sugar. So let's look at mom real quick. So we're over here on mom's side. What are some of the signs and symptoms mom is going to experience? She's going to have the 3 Ps, right? This is what we're looking at here. Our 3 Ps, you've probably known them, heard of them, and experienced them at some point in your life, but have all 3 is when you have hyperglycemia. So the polydipsia, the excess of thirst, polyuria, excessive urination or constant frequent urination, and then polyphagia, that increased hunger. All of these, along with other symptoms of hyperglycemia, is what we're looking at for mom. But for baby's got some other pathways that they're going to go down and experience. So with baby, we have that fetal blood glucose increases, right? So they have an increase in their blood glucose. And baby will have similar things as well. So first is baby's pancreas is going to increase that insulin growth. Because of that, it's going to trigger that pathway to then increase in growth. And that's where we have the macrosomia, or the big baby, right? They say gestational diabetes, you have that, your baby's going to be huge. And then we also have polyuria with baby. So baby's going to frequently pee a little bit more. And what that does is that causes hydramnios, or an increase in that amniotic fluid, right? So now baby's going to have bigger fluid. So This is a problem, right? Because mom's going to also have to experience, we got big baby and we got big fluid. This is going to be a big belly, right? So let's move into some of those complications that we're going to talk about, what all of these things can cause as a complication for mom and baby. All right, Ninja Nerds, so these complications that we're looking at. Let's start off right in the beginning. There is a chance for spontaneous abortion, though it is not as common. It is still a chance that with gestational diabetes, we can have a spontaneous abortion, and one of them has to do with the sugars being uncontrolled. So when mom gets a new diagnosis of gestational diabetes, there's going to be a lot of learning, a lot of scared unknowing, because we're going to have to figure out what's going on and how am I going to control this. There's also going to be the complication of possibly having a C-section or a difficult birth altogether. Remember, we just talked about that macrosomia, the hydramnios, where the baby's either going to be really big or there's going to be a lot of fluid. So that can cause the concern of possibly let's go for a C-section because we may have that difficult labor. With the hydramnios, we also are looking at the overdescendant of the uterus, which can then also cause pre-rupture of membranes within mom, and also the preterm labor. Again, we've got all that pressure, we've got all that big belly, everything's pushing in on each other, so we could have some issues with that. There's also the chance for mom to develop type 2 diabetes down the line. They say around 50%, can be more, can be less, but just understand there is an increased risk of developing type 2 diabetes approximately 5 years after you give birth. And then the last is hypoglycemia for baby after birth. So what does this mean? So this means immediately after birth, when baby has now entered the world, baby has been born, we cut that umbilical cord. Well, remember when we talked about earlier is when mom is the one that's taking in the sugar and baby is getting sugar from mom. So once we cut that umbilical cord, baby is no longer getting sugar. However, their pancreas is still going to pump out insulin for a little bit. And because of that, that insulin is going to go and drop baby's sugar down, and it can drop it down to a hypoglycemic level. So you just want to make sure that everybody is on board of keeping an eye on baby after birth, because baby can drop a little lower than normal. Let's move into how we diagnose and talk about how we figure out if mom has gestational diabetes, and then what is our plan and treatment for her. All right, so now let's talk about what's going on to how we diagnose mom for gestational diabetes. So there are some glucose tests that we will be doing throughout mom's visits to OB, but what we're looking at here is how does that become a diagnosis for gestational diabetes. So one is mom's just going to get those random capillary glucose tests when she goes in, and we want them to be around our normal range, which is 7 to 110, depending on your facility. And then every time mom goes in, she does provide a urine sample as well, and that's to see if there's any ketones or sugars or anything within the urine so they can do a urine analysis. But what happens if they see these constantly high glucose and they may have these constantly see sugars within the urine? They're going to want to send mom for an oral glucose tolerance test, or the OGTT. And there's two portions to this. So if you fail one, you have to move on to the next. So the first is the 1-hour glucose tolerance test. And what this is mom's going to go in. They can just get a non-fasting glucose. So typically what happens is, if these are positive within any type of visit, they can just move in to do this while they're there. Some may, some won't. It just depends on your facility and the timing and everything. But so if you have some type of positive, you're going to go for this 1-hour glucose tolerance test. You're roughly around 24 to 28 weeks possibly. It's going to be a non-fasting glucose, so they're just going to check your sugar. You're going to drink 50 grams of the oral sugar solution. I hear it's not delicious. And then you're going to wait 1 hour, and they're going to check your sugar again. And if it's greater than 130 is what they consider a positive. Now, some books and some texts may even say 140, and that just has to do with the percentage of which ones are actually diagnosing in the long run gestational diabetes. So 130 catches around 75 to 80% of women, and 140, you definitely 90% is going to have gestational diabetes. So just if you see in the text, some will say 130, 140, but regardless, you drink that 50 grams, 1 hour later you check your sugar. If it's greater than 130, you're going to move on to the 3-hour glucose test, because now you have failed the 1 hour. And the 3-hour takes more than 3 hours, because you also have to go in the beginning and get that initial glucose check. So the instructions for the 3-hour then are an overnight fasting. The patient's going to fast overnight. They want roughly around 8 hours, because that's where you're going to have your lowest sugar, because after that the body can start making its own. But anyways, we're gonna go in for that 8-hour overnight fasting. You're gonna avoid smoking, caffeine, eating anything in the morning. And when you get there, they're gonna take your fasting glucose. Great. Get your fasting glucose. You're gonna drink now 100 grams of the oral glucose. And then you are now going to wait 1 hour. In 1 hour, you will get a glucose check. And then an hour later, get another glucose check. And then 1 hour from there, get another glucose check. So you can see here, you're gonna have 3 hours within the middle of getting the glucose check, and then some of this in the middle here. So roughly around 3.5, maybe 4 hours in total to do this whole test. And what are we looking for? How does this work? So they get that fasting glucose. If it's greater than 95, that's considered a positive. But the numbers that we're looking at that are really important is after we drink that 100 grams, how does our sugar compensate throughout that time? How do we compensate? How does our body react to it? So if they have a positive of 2 or more, they are considered to have gestational diabetes. So let's look at it here. You go in, get your sugar checked. If it's greater than 95, that could be a ding. But we're going to go in to drink our 100, right? An hour later, if it's greater than 180, that will be a ding. An hour later from there, if it's greater than 155, and then an hour later from there, if it's greater than 140. So these are the numbers or the goal that we want to be under if we hopefully don't have gestational diabetes. But that's the numbers that your facility may look at in order to decide whether you have gestational diabetes or not. And remember, this is all patient-specific and facility-specific, because some patients, even if it says greater than 130 and they had 129, your doctor may be proactive and just send you for the 3 hour. Okay, so let's keep this in mind, as this is just how we diagnose, because there is questions on the NCLEX that they may ask you, how do you administer? What are you going to tell your patient? So just keep that in mind, and let's move into now the big problem is how do we treat these patients? All right, Ninja Nerds, so now we have found out that our patient has gestational diabetes mellitus, or what we're going to do is we're going to talk to them and try to teach them as to what's going on, because this is going to be very overwhelming for the patient. It's going to be a lot of things going through their mind, and a lot of patients particularly run into the issue of, why did this happen to me? Am I a bad mom already? I didn't even give birth. And we have to just talk them through them, explain to them what's going on with their body and how we can help them further along in this pregnancy with ease and confidence. So big thing for them is going to be the glucose management, which ideally the goal is to regulate them in the beginning with diet and exercise. So teaching them to regulate their diet. They don't have to go into a straight on keto. They don't have to go and eliminate all carbs. There is just got to be that give and take, that balance within their diet. And you also want to teach them about exercise. There is some information out there about if you walk for every amount of walking that you do after you eat, it can drop your sugar a certain amount of points, which is great. So you want to tell them about exercise, and it doesn't have to be invigorating. It doesn't have to be, go sign up for a half marathon. It just needs to be some light exercise, maybe some walking after a meal. They're going to have questions too about the monitoring of the blood glucose at home. How does this work? How am I supposed to do this? So the facility may prescribe them a glucose monitoring device, which they can take home. If you have it there in the office, I would advise you to take it out of the packaging, show them how it works, give them any examples that they need, what's the best way to get the finger prick in order so they feel confident when they go home to check their sugar. Because that monitoring at home is very important. You want to make sure you're telling them too, they're taking it right when they get up so that we can see what it is in the morning and then go from there. Don't want to be taking your sugars right after you eat. We all know this. This is the worst time to take sugar, because if you've ever had a patient who was supposed to have a blood sugar so you can give them insulin and someone accidentally gave them food, whether it was a family member or someone within the facility, now I can't check their sugar because it's not going to be accurate. So we want to make sure we take it when we wake up and before meals. Medications, so there is some different types of medications if they do warrant then needing the medications. There is either oral, usually metformin, although there is some debates on whether that is safe because there's not much research for that. And the long term after baby, and there's also insulin. So the preferred typically usually is starting with the insulin, but that is, again, if you've been tracking them at home and you're keeping an eye on it with your doctor and they warned that it is time to start insulin. That's not always the first step. Usually it's the diet and exercise. Then we're going to go into the possible C-section and the difficult labor. Again, you want to talk to your patient, talk them through, because they're at 24 to 28 weeks. Maybe it's a little later. They're a little after. Maybe it's 30 weeks. Like, baby's coming. They got a lot of things going on at home. Maybe they're getting the nursery ready, and you want to make sure you're talking to them about the possibility of having a C-section, possibility of giving birth a little earlier, and that they also will have a difficult labor. So walk them through it, tell them their choices, tell them, how this is all going to work so that they feel confident to make the right choice for themselves. And the last thing is the kick counts. Remember to teach your patient how to do kick counts at home. Make sure they know how to monitor babies kicking at home. A lot of moms who have issues with sugar, they will report that they drank orange juice and then they feel baby kicking a lot afterwards, which is a sign that the sugar has now gone to baby. But you want to make sure that they understand how to check on baby and their well-being altogether. All right, Nation Nerds, in this video we talked about gestational diabetes mellitus. I hope you liked this video. I hope it made sense. If it did, make sure to hit the thumbs up and comment down below. And as always, until next time.